Okay, so now we're going to complete with Chapter 41, Part 3, Malabsorption Disorders, Poisonings, and Other GI Issues. First, let's discuss celiac disease. It's an intestinal intolerance to gluten. Second leading cause of malabsorption in children. Gluten is in wheat, barley, rye, and oat grains. Chronic malabsorption syndrome characterized by intolerance of gluten, which causes the accumulation of amino acid glutamine, which is toxic to mucosal cells of the gut. Over time, the villi in the small intestine are damaged, which impairs their ability to absorb nutrients. It's diagnosed through blood work and then an intestinal biopsy via endoscopy. Screening can be done through HLA genes and anti-gliadin antibodies for immunoglobulin A and immunoglobulin G, anti-endomysium, IgAM, and anti-tissue transglutaminase IgA and abdominal IgG. The picture in the upper right corner shows the child who has skinny arms and legs but has a pot belly. That is characteristic of celiac disease. Other symptoms include not growing well, failure to thrive, irritability, the child stating that they don't feel good, poor absorption of proteins, fats, and carbs, eczema, and lack of attention, focus in school. They can also have chronic diarrhea, poor appetite, lack of energy, iron deficiency anemia, a short stature, abdominal distension, muscle wasting, hyponatremia, delayed puberty, dental enamel defects, alopecia, and abnormal LFTs. Early symptoms can appear between 6 months to 2 years. Treatment is gluten-free diet. Okay, for short bowel syndrome, it occurs after extensive bowel resection or malrotation or gastroschisis or atresia, and impacts growth and the ability of the child to gain weight and sustain life. Basically, what happens is there is not enough bowel left over to adequately absorb nutrients before the food is dumped out of the ostomy. Initially, for the first 3 months post-op, it's normal to have watery stools, but it must be monitored closely for dumping. Watch for the ostomy output to suddenly increase a lot after PO feeds. Treatment usually is TPN and it allows to give the gut time to grow. Bowel transplants are a new thing. Otherwise, these children stay on TPN, but they'll eventually have risk for the liver and causes of jaundice. Let's look at poisoning. Potential poison risks for children include, but are not limited to, cosmetics, personal care products, cleaning supplies, plants, adult medication, heavy metals, lead poisoning. Not as much as an issue now because paint is made without or with very low levels of lead. Could be foreign bodies, desiccants, bubble blowing solutions, batteries, magnets. Look at Table 41-19 on page 1305 to 1306 for a comprehensive list and comments on poisoning risk. Children will stay with grandparents or great-grandparents or sitters even who don't have child-proof caps on their medicine because of their arthritis or for other reasons. And children get into their medicine. Very common tell in the ER. Heavy metals such as broken thermometers, broken fluorescent light bulbs, disc batteries, gas regulators, interior latex house paint. Mercury is volatile room temp and can be inhaled. Nursing care. Treat the child first, not the poison. No Epicac. Take vitals, secure the airway, initiate circulatory and respiratory support as needed. Establish an IV. Place NG tube for lavage. Administer activated charcoal slurry, which will absorb the toxin. Add some soda to give it flavor. Always consult the Poison Control Center. They are the experts. Sometimes, depending on the poison, children just need to drink more to dilute the poison out. Other GI issues. You should have already talked about the NEC already in OB class. It affects babies, mostly preemies. The recurrent abdominal pain, more common among school-aged girls, affects 12% of children. They complain of periumbilical pain on a regular basis. Cannot be attributed to a single cause. Seems to be related to stress. Teach relaxation techniques and ways of coping with stress. There's biliary atresia. Extrahepatic bile ducts fail to develop or are closed, leads to cholestasis, cirrhosis, end-stage liver disease, and death by age 2. Jaundice is usually the first symptom, but that is 2 to 3 weeks into it. Treatment is a liver transplant. We have Hep A. It's transmitted via fecal oral route, contaminated food and water, particularly shellfish, and can get outbreaks in daycares. And then we have cirrhosis. In children, it occurs as a result of end-stage liver disease, usually from biliary atresia or hepatitis. This concludes the lessons of Chapter 41.